Morning.
Sister.
We are going to start. Last week, we talked about anemia. We talked about complicated. Yes, please. Martina, anything or matter? If nothing, mute yourself. This morning, we are going to talk about hyperemesis gravidarum. And we know that hyperemesis gravidarum is a serious condition in pregnancy. Hyperemesis gravidarum is actually not an English word, or they are not English words. So hyper is excessive. Emesis, we all know what emesis is vomiting. And then gravidarum is pregnancy. Nausea and vomiting of moderate intensity are especially common until about the 16th week. HCG occurs when vomiting becomes interactable in early pregnancy and cause fluids and electrolyte imbalance, as well as nutritional deficiency. In a situation like this, women need to be hospitalized. So what is hyperemesis gravidarum? How will you define it? It is a severe type of vomiting in pregnancy, avoid the dead, please, which has gotten, just a minute, this thing is blocking me. That is why I always, which has deleterious effect on health of the patient and or incapacitates her day-to-day activities. If you have ever nursed a patient with hyperemesis gravidarum, you will see that she actually cannot do anything for herself because she's ever retching and vomiting. She will retch and vomit to a point that her throat begins to tear, and so her vomitus become bloodstained. So we look at it again. Severe type of vomiting in pregnancy, which has deleterious effect on the health of the patient and or incapacitates her day-to-day activities. I will not want to ask for your experience because it will delay us. We have 2 topics to discuss today. But I had an opportunity of witnessing hyperemesis gravidarum at home. At that time, I was still in secondary school. I was not a nurse. And it had to do with my elder sister. So when I got to do midwifery, I said, I had seen it. All the features, being incapacitated, not able to do anything. That was why I was easily convinced that the blood comes from the throat. Etiology. The causes of hyperemesis gravidarum are said to be idiopathic, but could be related to hormonal changes. When the level of HCG is high during pregnancy, severe vomiting occurs. Other risk factors are overweight, multiple pregnancy, the presence of trophoblastic disease, which involves abnormal growth of cells in the uterus, and then psychological factors. In the case of my elder sister, it was multiple pregnancy. It was multiple pregnancy. Does somebody have anything to say? Do we continue? It is
Yes, sister,
limited.
please.
It is limited to first trimester. More common in first pregnancies. Remember, they say more common is not absolute. In the case of my elder sister, it was actually the third pregnancy. Tendency to recur in subsequent pregnancies. Familial history. Cecilia, don't you ever repent?
Cecilia Munga, mute yourself.
Are you sure she's close to the system? She may not. Mother and sister may have suffered from hyperemesis gravidarum, more prevalent in high datidiform mold and multiple pregnancies. Please, can somebody read that last sentence?
Common in unplanned pregnancies.
In unplanned pregnancies. The phone, I will still use my sister as a case study. No history of multiple pregnancy in the family. Her husband's family, none. Our own family, none. And she had it. So most times, what we hold on may not really be facts. Risk factors: age below 17 years and over 35 years. Primary gravida, multiple pregnancy, underweight, and obesity. So when you talk about weight, on the two extremes. Psychological factors such as unwanted pregnancy, marital problems, hyperemesis, or severe hyperemesis gravidarum. I don't know why that point is there. Then trophoblastic disease, yes. So what happens is that all these risk factors are okay, but when we look at psychological factors, such as unwanted pregnancy, I don't know, you and I, or maybe you have observed differently. But unwanted pregnancy, especially if it has to do with the ages below 17, in practice, those children are hiding it. They don't want somebody to know. So most of these abnormalities, they will not even spit. They won't salivate. I don't know if you have noticed separately. But again, it depends on where this information is coming from. Because for those ones, then marital problems, again, I do not know, but when it comes to psychology or psychological factors of this condition, you are actually looking at pregnant women who need attention. So probably marital problems, they need attention. But the young lady whose husbands are loving, they are happy in their marriages. Psychologically, they need more attention. They can behave that way. Or this is good to discuss. Or what have you observed?
Hello, Prof.
Yes, please.
Please, this is Zoera. With the
Yeah.
first point of the first one you mentioned, like unplanned pregnancy. For me, what I've noticed is that one, I don't agree with this point because most of the young girls I have seen that have not planned the pregnancy, you don't even see any symptom on them.
They don't
They don't even
salivate.
they don't even overeat for you to say they have changed. They don't salivate, they don't vomit,
They
nothing.
don't do anything for
Some
you
of
to
them
know
will go
because they
up
are
to
hiding
9
it.
months. Some will go up to 9 months without even noticing any sign of pregnancy. So for that one, I don't agree. And the other point of marital problems, most of those who have hyperemesis, they have loving husbands because the ones I admit at my unit, the husbands are very close and caring. That is what I have seen, but I have not seen those have been rejected and then they are vomiting too much. The ones I see always has loving husbands. Thank you.
You see, thank you for confirming what I purposely, when I was working on this, I saw this thing. And I said, okay, let me put it down here so that maybe where I am coming from is different, so that I hear what obtains here. Unwanted pregnancy, you can't see it, particularly children below 17. No. These ones are still in school. Very few at this age are in the university. My mother will kill me. My father will kill me. And so no sign. I don't even know how they manage it. It is only when the skin changes, the abdomen begins to grow that people begin to suspect. And most times you ask them, they deny. So I put it here purposely for us to see it could happen in other parts of the country, of the world. But for us, it's a lie. It does not. Now, there is high level of HCG when we are talking about hydatidiform mole, when we are talking about multiple pregnancy. So the hormones becomes quite high. High estrogen, high progesterone, relaxation of the cardiac sphincter because the progesterone level is high. And then other hormones involved are like the thyroxine, the prolactin, the leptin, the adrenocortisone. All these levels, all these hormones are usually high. And that is why the woman vomits excessively. Then psychogenic. It probably aggravates nausea once it begins. It now triggers the neurogenic elements. So it is possible. It is possible that the high level of hormone aggravates nausea because it triggers the neurogenic elements. So that could be a possible cause. Then dietary deficiency, probably due to low carbohydrate reserve, as it happens after a night without food. Deficiency of vitamin B1, B6, and protein may be the effect rather than the cause. And another thing is, I tend to agree with this dietary deficiency. When you see somebody that is highly dehydrated. The person has nausea, the person vomits. That person is dehydrated, the person is not eating well. The person has nausea, the person vomits. Have you observed that? That's my own observation. And in fact, I observed it on me. That was when I noticed it. There was a time I was very dehydrated. I wasn't like sick, but I wasn't, I was depressed. I was not eating well. I started vomiting. In fact, my late husband, at that time, I've not had a child yet. My late husband thought I was pregnant, but I knew I was not pregnant. Have you observed that?
Yes, I see. I'm sorry for that.
Vomiting in dehydration. And somebody is severely dehydrated. So it could be this dietary deficiency. Number 4, allergic, or it could be immunological basis. That is, the person could be allergic to a particular thing or immunological basis. Then it decreases gastric motility. Because you are not eating anything, because there's nothing in you, the gastric motility is decreased and it has a cause on nausea. Again, we are talking about dehydration. Again, we are talking about dietary deficiency. Then the clinical cause. You see it vomiting, that is when it starts, she vomits throughout the day. Normal day-to-day activities are disturbed. No evidence of dehydration and starvation. I again want us to discuss that point. No evidence of dehydration and starvation. What have you noticed? Hyperemesis gravidarum. I like interaction. That is why for a common condition, yes. Samira too.
Yes, sister. Please, with the no evidence of dehydration, I don't agree with it. Because
Good.
with those with premises gravidarum, you see them, they are very weak, and then you see their skin is, it's like the
Their
elasticity is
skin is
very
elastic. They are dehydrated. They do not eat.
yes.
They do
They don't
not
feel
eat
like eating anything.
because anything they take, they vomit.
Oh, yes.
Anything they take, they vomit. Why I am putting all these points here is for us to, I want to confirm what happens here. Probably in the country where this is put, that is what happens. But the question I want to ask is, this person is vomiting every liquid that goes into her. This person cannot retain any food. How can there not be evidence of dehydration? Because if we don't discuss it here, somebody sees it, the person might swallow it like a pill, and it's not correct. And most of you that are here, you are lecturers, you are tutors in schools. So you may be asked to prepare notes and go and teach hyperemesis gravidarum. And you bring this point and begin to argue. And then a student goes to the service area and says, my teacher said this, but this is what we see here. So it is not everything we see in the net that is correct. And the same thing, okay, it is early they are talking about. Late, evidence of dehydration and starvation. When they say early here, I don't know how early. Because it is a normal thing. You continue vomiting. Probably the person who wrote this may have seen this person on the first day. I don't know. Are you following?
Yes, sister.
Maybe the person saw the person on the first day. But for us here, our people will not come to the clinic so early. It starts today, you begin to come to the clinic. No. And for every human being, you don't take water, you don't take food. In 24 hours, we will know that there's something wrong. At least now, we have a vivid example. The Muslims are fasting. The weakness is there. Symptoms: excessive vomiting and retching day and night. There is epigastric pain. There could be constipation. Of course, when you talk about tialism, you are talking something, you are just adding it because she's continuously vomiting, and when she's not vomiting, she's spitting out. That is, she's salivating excessively. Then there is fatigue. There is bound to be anorexia. Complications will appear if not treated. Who can tell me what anorexia is?
Hello, Prof.
Yes, please.
Please, it's loss of appetite.
Loss of appetite. Thank you. Then signs of dehydration and ketosis. Ketoacidosis. How do we observe the ketoacidosis?
That is when we find ketones in the patient's urine.
But how do you, well, apart from going to, I walk in, how do you know?
So I will test the urine for ketones protein.
Elizabeth Nyankon, please off your camera.
No, you haven't gotten to that.
Sister, please.
The color
When
of
the
the
person
urine.
speaks to you, from her mouth, you can smell the acid, the
God
ketones
bless
in
you.
the mouth.
God bless you. God bless you. From
Smell
the
coming from the
person's
mouth
breath.
when the person speaks.
From the person's breath.
My sister,
You
from
can
their
smell,
sweat.
you can smell acetone. You can smell acetone. Well, it may come from sweat. I don't know how to detect it from sweat, but I know as soon as she comes, you smell acetone in the person's breath. And do you know that there are people, the very fat people, they are not pregnant, they are not sick, but they smell acetone. Who can tell me why? Very fat people. They are not pregnant, they are not sick, but they smell acetone. Their breath smells acetone. Who can tell me why?
Sister, please, I think it's a sign of starvation when they are hungry, or it's a sign of hypoglycemia.
I think so too. In other words, they eat, but they don't eat enough. That is, they eat and they feel they are okay, but their tissues are starving. You understand what I mean? Hello.
Hi,
Hi.
sister.
Do you understand what I mean?
Yes,
Yes,
sister.
Yes, they have eaten. If they want to eat according to the demands of their tissue, they will eat much more than what they have eaten. Then there is tachycardia, postural hypotension. There is a rise in temperature. In later stage, the person could be jaundiced. Then you have vaginal examination and ultrasound done to confirm that that woman is pregnant. Sorry, you want to rule out any other disease. You want to confirm that actually what she's going through is hyperemesis gravidarum. Because if she's not pregnant, then it could be a diseased condition. Now we want to do investigation. You want to find out urinalysis. What is the problem? The quantity, you want to look at it. The color, you want to look at it. The specific gravity. Definitely in these cases, they will have oliguria. Their urine will be concentrated because they are not taking anything. The specific gravity will be high. Then the presence of acetone, occasional presence of protein and biopigments, and then diminished or even absence of chloride in severe cases. Number 2, biochemical and circulatory changes. The serum electrolyte, that is the sodium, the potassium, and the chloride. You want to look at their concentration. Then you are looking at the eye, ophthalmoscopy. It is required if patient is seriously ill. Retinal hemorrhage and detachment, that retinal detachment, may be one of the conditions. And it could be a very unfortunate and unfavorable sign. Prof, what do you mean? Hyperemesis gravidarum going that far? Yes. I don't know if you have ever retched. When you retch, your whole system is destabilized. And when this one continues the way it does, there is bound to be detachment of the retina and bleeding in that area. Where there is abnormal serum potassium, or where there is abnormal serum potassium level, ECG can be done to confirm. Electrocardiography. Diagnosis. Pregnancy is first confirmed. Associated causes of vomiting are excluded. They could be gynecological, medical, or surgical causes. Then, of course, the ultrasound to confirm pregnancy, which could be a single pregnancy. Most times, when we talk about it, we're talking of multiple pregnancy or disease condition, hydatidiform mole. Other complications, stress ulcer in the stomach, esophageal tears. I've told you about that. The esophagus tears. Jaundice due to liver damage. because of the constant retching coupled with dehydration and all. So see, have you ever seen the stress ulcer? That's the stress ulcer there around the umbilicus, around the navel. Prevention. The only prevention is effective management to correct simple vomiting in pregnancy. That's the only preventive measure. Active and effective management. And the question now is, what is active management of hyperemesis to prevent hyperemesis gravidarum? When she starts early, and let's pray she comes to the clinic early, to the facility early. All you do is to put her in bed, keep her hydrated, begin to give her the counsel to come out of bed gently and to go back to bed gently. The nurse or the relation should be there to attend to her. She is hydrated continually. And then you begin to give her the lukewarm tea, the crackers, or the toasts. She takes them so she can retain them. They will not irritate her. Management. The principle is to control vomiting. The principle is to correct fluid and electrolyte imbalance. The principle is to correct metabolic disturbance and to prevent serious complications of severe vomiting. So a way of controlling vomiting, we have a lot of ways. You want to, in our native way, the star apple helps salivation, it could help that. A piece of ginger in her mouth or bitter cola in her mouth. And then the hydration you are doing by IV infusion will also correct electrolyte imbalance. Then we talk about you correct metabolic disturbance. With the fluid, it could also help. And then while she is there, you're giving her the dry biscuits, the toast bread, that also can help. And with all this, severe complications are avoided. All what we have said there in the management cannot be done if she is at home. So you admit the patient. You open an IV line to correct the fluid balance. Send for relevant investigations. Maintain intake and output charts. Monitor urine output. So you may want to catheterize her so that you monitor the amount of fluid that goes in and the amount that comes out to ensure that her kidneys are working well. Then you monitor the vitals, test urine periodically. Because she is on infusion, you want to test the urine because that infusion helps maintain metabolism. So you want to ensure that the ketone bodies are eliminated. Oral feeding is withheld for at least 24 hours after the cessation of vomiting. Remember, I told you that when you open the IV, you are also maintaining the metabolism. you are feeding her in that area. So if you find that what she takes per oral triggers vomiting, hold on to it. Hold on to it. During this period, fluid is given through IV, through the vein. The amount of fluid to be infused in 24 hours is calculated as total amount of fluid, approximately 3 liters, of which half is 5% dextrose and half is Ringer's lactate. So you are giving her in 24 hours, 3 liters. At least, even though it is much, it has to arrest that situation. And you are not giving all dextrose in water. You are giving her dextrose, and depending on her condition, you either give her dextrose in water or dextrose saline. Then extra amount of 5% dextrose equal to the amount of vomitus and urine in 24 hours is to be added. So as she is vomiting, as she is passing the urine, when you have given the 3 liters, you give an extra amount of 5% dextrose to equal the vomiting. Then these measures help to correct, number 1, dehydration, 2, electrolyte imbalance, and ketosis. Nutrition through nasogastric tube may also be given if, that is the word they may. Most cases, they don't get to that level. But if they get to that level, it may be given. Antiemetic. Whatever antiemetic that is used could be given intramuscularly, whatever one that is prescribed, as we have listed them here. You have prednisolone, which is given orally. In other words, the situation has been controlled. The nutritional support, the various vitamins could also be given that will boost the person's appetite. Nursing care. Number 1 is symptomatic, but we must be firm in handling the patient. Daily monitoring of patients. We look out for signs of improvement in the patient. We look at how much the vomiting has subsided. We want to find out if there's any feeling of hunger, if she looks better, disappearance of acetone from her breath and urine, normal pulse and blood pressure, normal urinary output. We look at the lab results for things that are supposed to be there when somebody is dehydrated. Then, of course, one of the most important things, as the woman's life is important, this one too is important. You want to monitor the fetal heart rate. You want to check the fetal activity, and you want to also see the growth. Encourage this patient to sit upright after meal. Encourage small, frequent meals, especially as she's coming out. Those dry biscuits, as we talk, and the warm tea. Liquid should be taken between meals to avoid distending the abdomen, which could trigger, what word is there? What?
Vomit.
Vomiting. Okay. That is it. You know, she hasn't been eating for some time. So you have to encourage her to take a lot of fluids as she's eating, and then to sit up right. Take small food at a time. Obstetric care. I don't know if with hyperemesis gravidarum there will be need for therapeutic abortion. I don't think so, except something else happens. It is seldom indicated. Well, the renal conditions, the renal complications resolve actually after management, but the obstetrician will know best. Then the dietary management. Before IV fluid is given, oral, small, and frequent dry meals without fat are given. First, dry carbohydrates like biscuits, cream crackers, biscuits. This biscuit that is lying here is sweet. I don't know, maybe their own will not be sweet, but it can be sweet. Then toast bread. The bread we are looking at here is not toasted. You toast the bread because you don't want any fat. But if the bread is dry enough, it can be given. Ginger is helpful, like I told you earlier. And then gradually, full diet is restored. Thank you very much. Contributions. Or questions?
Hello, sister.
Yeah.
Um, please, with the medication for the hyperemesis gravidarium,
Yeah.
I saw IV promethazine, but I didn't see the oral one. Does that mean the
You
oral
didn't
one,
see?
the oral promethazine?
Okay.
So
Ask your question.
the, sister, please, in our facility like this, we've been given the suspension promethazine instead of the IV.
Okay.
So I wanted to know.
Remember when I got to the IM and the IVs, I told you that it solely depends on the obstetrician. I only started mentioning when we got down to the oral ones,
Okay.
depending on the condition. Justina. So I told you, I just scrolled through. I said it depends on the obstetrician. I only started talking when I got down to the oral ones. So when you talk about the IM and IV, it depends on the severity, number one. It also depends on who is handling the situation in respect to the medical officer. Because hyperemesis gravidarum, even if you are in the clinic and a patient comes with it, do you handle it there? You refer, don't you?
Sister, please, it depends on the severity.
It depends on the severity.
Yes.
When it has to do with that name, hyperemesis gravidarum, where that person vomits continuously and cannot do anything to help self, it is advisable to transfer. Hello.
Hi, sister. Thank you.
When it is ordinary vomiting, that person is vomiting, maybe vomits 2-3 times a day, that is okay. But when you look at it and you say it's hyperemesis gravidarum, you refer. Because that person is completely out of any daily activity. Hello.
Hi, sister.
Hi.
Are we okay?
Yes, sister.
Yes, sister.
Okay, Teresa. Teresa, you will be our teacher today for this one. Are you available? I don't know how many Teresas there are, but the last Teresa that said yes, sister. Are you available? If you are not, who volunteers, please?
Sir, please, I'll volunteer.
Okay, Victoria, God bless you. So, hypertensive
Amen.
disorders in pregnancy. Continue.
Definition disorders.
Victoria, your network.
Okay. Sir, please, can you hear me?
Yes, I can.
Okay. Hypertension disorders of pregnancy, also known as maternal hypertensive disorders, is a group of disease that includes preeclampsia, eclampsia, gestational hypertension, and chronic hypertension. Start, please, next thing. Classification of hypertension in pregnancy. So we have gestational hypertension, preeclampsia, eclampsia, chronic hypertension, and then the last one is preeclampsia or eclampsia superimposed on chronic hypertension.
Preeclampsia or eclampsia superimposed on chronic hypertension. In other words, that woman already has chronic hypertension, and then it graduated to either preeclampsia or eclampsia.
So we will look at preeclampsia pregnancy-induced hypertension. So in preeclampsia pregnancy-induced hypertension,
Preeclampsia pregnancy-induced hypertension. It means that when some people have preeclampsia, most times those people are not hypertensive. Their hypertension is induced because of their pregnancy. That's why it is called pregnancy-induced hypertension. Continue.
a multisystem disorder of unknown etiology characterized by development of hypertension to the extent of 140-90
millimeters of mercury.
proteinuria after.
Hello.
Okay, sister.
140-90 millimeters of mercury.
of mercury or more with proteinuria after the 20th week in a previously normotensive and non-proteinuric woman.
Previously normotensive or non-proteinuric woman. This woman previously does not have any of these problems. The problems are induced by pregnancy.
Classification of preeclampsia. A. Primary, 70%. So in the primary, we have 70% preeclampsia and then eclampsia. And then B, secondary, we also have 30% preeclampsia, eclampsia, superimposed on chronic hypertension. Sister?
Go ahead.
Okay, so that one too is 25%. And then preeclampsia, eclampsia, superimposed on chronic renal disease is 5%.
So what we are saying here is that under classification of preeclampsia, we have A and we have B. And the A carries 70%, while the B carries 30%. So under the A, the patient could be preeclamptic or eclamptic. Now, under the B, we are told that most of the people who have preeclampsia, a majority of the people have preeclampsia, which is actually superimposed on chronic hypertension. In other words, these people came into pregnancy with hypertension. They are known hypertensive people. And in that condition, you have 25% of them. While 5% will be those that are have renal conditions. That is when it comes to them. Those who have renal conditions, 5%. But they also may have had hypertension before they got pregnant. Continue. Omia, please, I'm in class.
Classification based on severity. So we have 1, mild preeclampsia. 2, moderate preeclampsia. And 3, severe preeclampsia.
Please, just give me 1 second. Continue, and as you continue, you explain. I'll be with you in a moment.
Okay. Okay, sister. So with the mild, moderate preeclampsia, the systolic BP is 140 to 160 millimeters of mercury. And then the diastolic, it ranges from 90 to 100. Urea is up to 2 classes. So it means that with the mild, moderate preeclampsia, when you check the systolic blood pressure and then you get 140 to 160 millimeters, you should be thinking of mild, moderate preeclampsia. And then diastolic of 90 to 100, ranging from 90 to 100. And then during your proteinuria, you also get 2 classes. And then, so the severe preeclampsia, with that one, the systolic blood pressure is greater than 160 millimeters of mercury. And then the diastolic is also greater than 110 millimeters of mercury. And when you come to the proteinuria, you will get 3 classes or even more. And then the patient will also complain of epigastric pain. Next, please. Please, do we understand?
Yes, sister.
Yes,
please.
Yes.
Okay. So we continue. So let's look at the risk factors. We have primigravida, that is young or elderly. So as sister mentioned earlier, the teenagers, and then the elderly are those above 35 years. Family history of hypertension or preeclampsia. So if you have a nearest relative who has suffered from this condition, then you should also be mindful of it. And then the third one is placental abnormalities. So when we talk of the placental abnormalities, we are looking at hyperplacentosis, that is molar pregnancy, twins or diabetes in pregnancy. So those who are having this condition, they will have a problem of hyperplacentosis. And then the second one is poor placentation.
As you finish, you people will deliberate on that. I'll be with you in a moment. Let me just get into the washroom.
Please, can somebody help with the placenta abnormalities? That
Are
is
you
poor
tired
placenta.
already?
Sir, please, I'm reading.
Which
Hello.
one do you want help?
Poor placentation.
Poor placentation. Poor placentation, it could be that the implantment of the placenta is poorly implanted.
Okay.
Yes,
Thank you.
that's what they mean by poor placentation. Or even there could be an abnormality in the placental tissues.
Okay.
In
Thank you,
other
sister.
words, everything that has to do with the placentation is abnormal. Just continue. I'll be with you in a moment.
Okay.
Any
Then
point? Okay.
placenta ischemia.
Take it point by point until I come.
Okay, sister. Placental ischemia. So when we say ischemia, that is inadequate supply of oxygen to the placenta. And then molar pregnancy. We all know molar pregnancy has to do with missed pregnancy. So we will move to genetic disorders. Genetic disorders. So it means that one has to do with individual differences based on the genetics of that person. And then we also move to immunological phenomena. So this one will have to do with the immune system of that person. The immune system of that person, which will predispose the person to this condition. And then pre-existing vascular disease. So this one can be the person who is already suffering from a vascular disease. Let's say atherosclerosis, the person blood vessels is already blocked. Hello, please, are we following?
Yes.
Yes,
Yes, we are
Yes.
following.
Am I on the right path?
yes.
And then new paternity. Please, can someone help with the new paternity?
Yes, please.
Uh-huh. I think please, I can't hear anything. No.
Hello.
Hello.
I think it will be a new husband or a new partner.
Oh, okay. 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 And then what about the thrombophilias? Thrombophilias. Please, can someone
Clotting
help with
factors
that one?
disorders.
You said?
Clotting factors disorders.
Thank you very much. Please, sister is not around, so let's wait more so that you can move us to the next point.
Hello.
Yes.
Please, placenta ischemia is reduced blood supply to the placenta or lack of blood supply to the placenta, not oxygen.
Okay. Thank you, Sister Zuriati.
Hello.
Hi. Sister, please, we are done with the points and the risk factor.
Okay. So you have seen the risk factors that could cause pregnancy-induced hypertension. And the first point is very correct, particularly the young ones, primary gravida. But one thing I want you to know is that as soon as the placenta is out, the condition is in control. That is the issue. That is why most times people say nobody really knows what the problem is. Nobody really knows what the placenta carries. Continue.
Etiology of preeclampsia. 1. Placental implantation with abnormal trophoblastic invasion of uterine vessels. Abnormal trophoblastic invasion of uterine vessels. Sister, please, can you help with this one?
Abnormal trophoblastic invasion of uterine muscles. You'll find out that there are situations where the trophoblastic vessels could invade the uterine vessels, which is usually abnormal. So when it happens like that, something abnormal comes up.
Thank you, sister. 2. Immunological maladaptive tolerance between maternal, paternal, that is placenta, and fetal tissues. So immunological maladaptive. So it means there will be some form of intolerance between the mother and the father, like the placenta tissue that is placed in the mother to so I learned something that the placenta is like a parasite. It is making sure that the baby is well fed, is there to protect the baby, to make sure everything about the baby is done correctly. So if the woman's immune system is not able to adapt to these conditions, it may lead to these preeclampsia or hypertensive disorders in pregnancy. So please, if you add something to it.
What are you talking about?
Immunological
maladaptive tolerance between maternal and paternal. When it comes to that, it has to do with the genes, fetal tissues. When there is maladaptive, when there is intolerance between maternal and paternal genes, what happens is that it results in the placenta, because it is through the placenta that they move up and down. And then the fetal tissues are affected.
Okay, thank you. So the third one is, the third etiology of preeclampsia is maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy.
Yes, but before we continue, there is something I came in and I heard you people talking about. What was it? Placental ischemia. What was the explanation that was given?
Okay, our sister prompted us that when we say ischemia, it means inadequate blood supply to the placental site.
The placenta site.
Yes.
Yes.
Blood supply
Blood
is
supply is
restricted. Blood flow
restricted. Blood flow
is restricted
is restricted
to that site.
to that site.
And because
And
of that,
because of that,
oxygen supply
oxygen
also
supply
is
also
deprived.
is deprived.
I don't know whether you
I don't know
understand.
whether you understand.
Blood flow to that area is restricted. And you know that it is the blood that is the oxygen, that has the oxygen carrying capacity. So when blood supply is deprived or is restricted, let's use the word that is used. When there is no free flow, oxygen supply will be restricted. So they go hand in hand. And that's why you have the pain. Ischemic pains in the capillaries, in sickle cell, ischemic pain in the placental site, because there is obstruction of blood, restriction of blood supply into the smaller vessels there, or into the vessels. There is a kind of clogging, arterial obstruction kind of. The arteries are not allowed, if you like, that's the restriction, to carry blood flow smoothly. There are some clots found in the vessels, and those clots cause constriction. And with that constriction, oxygen is deprived in that area. That's why we have pain. Because I overheard you people, one person talked about oxygen deprivation, another person said, no, it has to do with blood restriction. But no, it has to do with the two. Blood cells, the heme in the blood, is the oxygen carrying capacity of the blood. Now, when blood flow is restricted, when there is constriction anywhere, when there are clots clogging anywhere and the blood flow is restricted, oxygen supply is bound to be deprived. Are we all right?
Yes, sister.
Yes, sister. Yes, sister.
So here we are talking about maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy. Period. Simple. The maternal tissue cannot adapt to either cardiac problems or inflammation of any part during pregnancy. And because of that, there is a problem. In other words, during this pregnancy, for whatever reason, there is problem in the cardiovascular system. There is inflammatory changes in the normal situation of the placenta. And so the maternal tissues cannot adapt. The maternal state of the woman cannot adapt. And because it cannot adapt, then the woman's blood pressure goes high. The last one are genetic factors. It could come from the genes, and so problem ensue. Here we are looking at the pathogenesis of preeclampsia. The etiology is unknown. You have inadequate implantation, placentation. In other words, there's just like you saw poor placentation, there is a problem that one cannot understand with the placenta. Then you have the uterine spiral arteries, which are poorly invaded by the placental tissue. That is the cytotrophoblasts. They are poorly invaded uterine spiral arteries. That is, the normal spiral arteries in the uterus are poorly invaded by the cytoplasm. And once that happens, one of two things happen. The uterine spiral arteries, poorly invaded by the cytoplasm, give rise to incomplete or pseudo-vascularization. Incomplete vascularization, pseudo-vascularization. That is a false vascularization, which results in decreased placental perfusion. The placental activity is reduced. And after that, it gives rise to constrictive properties of the arteries. Constrictive properties of the arteries are remained. Alternatively, the cytotrophoblast fails to replace the tunic media. In other words, in normal circumstances, the cytotrophoblast should replace the tunic media during the growth and the division. It gets to a stage where the tunic media will cease and the cytotrophoblast takes over. But when you have uterine spiral arteries, which are poorly invaded by the cytotrophoblast, because the cytotrophoblast has not done its work there, it fails to take over from the tuner media. And once it does not take over from the tuner media, you have again incomplete pseudo-vascularization. And once you have incomplete pseudo-vascularization, the placental perfusion is decreased. And when it is decreased, apart from giving rise to constrictive properties of the arteries, it also can cause vasoconstriction of these properties. And vasoconstriction will result in increased blood pressure. We are seeing why this blood pressure develops. You look at it again, the constrictive properties of the arteries which remain give rise to vasoconstriction, which in its turn also gives rise to increased blood pressure. Now, this increased blood pressure gives rise to endothelial dysfunction. The endothelium fails to function properly. This gives rise to glomerular endothelium, which is damaged. And then filtration capacity fails. You have what is manifested before you is proteinuria and edema. So that is the pathophysiology of pregnancy-induced hypertension. Can you continue or do I continue? Abnormal weight gain results, clinical features of preeclampsia. When we talk about abnormal weight gain, we are talking about edema. More than 5 pounds monthly or 1 pound weekly in later months. Then, of course, there is rise in blood pressure. You find ankle edema, which eventually spreads all over the body. Then you have the pulmonary edema. On abdominal examination, there is chronic placental insufficiency. When an ultrasound is done, there is scanty lipo. What do we call scanty liquor? What's the name for scanty liquor?
Oligohydramnios.
Oligo what?
Hydramnios.
So many people are talking. One person.
Oligohydramnios.
Thank you very much. Mild symptoms. There could be slight edema over the ankles, which persists on rising from bed, or tightness of the ring on the finger. Once the ring becomes tight, that is an early manifestation of preeclampsia edema. Gradually, the edema may extend to the face, abdominal wall, vulva, and even the whole body. Alarming symptoms: headache, occipital or frontal region, disturbed sleep, insomnia, diminished urinary output. That is, the urinary output is less than 400 ml in 24 hours. It is small. We call it oliguria. There is epigastric pain. Angela Appiah, you are welcome. Please mute yourself. Then, of course, the eye symptoms. You have blurring vision, dimness of vision, or even complete blindness. Investigations. Who can help with investigations?
Sister, please, I'll continue.
Oh, okay.
Investigations. Urine proteinuria. So it means there will be protein in urine.
There is ophthalmoscopy, the ophthalmoscopic examination, which will show
Ophthalmoscopic examination. That is retinal edema. Blood. Hello.
constriction of the arterioles,
Blood values. That please the BUN, BUN.
What is BUN? What is BUN, class? I give you that as an assignment. Continue.
Urea nitrogen.
Please, we didn't hear. BUN.
Continue. I give you that as an assignment.
Okay, sister. The blood values. We also have thrombocytopenia, coagulation profile, and then liver function test. And then the antenatal fetal monitoring, ultrasound scan. We do ultrasound scan. We also do fetal cake counts, cardiotocography. We also do umbilical artery flow, velocimetry, and then biophysical profile.
Yes, have you finished explaining?
Okay, so the USG is the fetal scan, and then the fetal K count. That one you can ask the woman, you give the woman paper, and then you ask her to count. Anytime that the baby kicks, she should take it. And then the cardiac topography, that one it is done in the hospital. So they use it around the woman's belly, and then it will generate a report for you to know how the FHR is. And then the umbilical artery flow velocity. Step, please, can you help with that one?
Velocity is the strength of the flow. We are talking about, okay, velocimetry. We are still talking about the flow, the viscosity, how the flow goes. So for the BUM, we are talking about blood urea nitrogen. It is a test that is done to see the functioning state of the kidneys. And then you have the biophysical profile. You're also looking at all the profile, the functioning activities in the body. Yes, Victoria.
Maternal complication. So the immediate complication in antenatal. Then we have eclampsia, 2%. So we may encounter 2% eclampsia. And then accidental hemorrhage. We also have oligourea and then anuria. So oligourea is urine. Class, please. What is
So what is
anuria?
anuria? Class,
Lack of
midwives.
urine.
Lack of urine. Thank you very much.
Lack of urine. And
Continue.
then dimness of vision. Dimness of vision and even blindness. There may also be preterm labor. And finally, HELP syndrome.
What is HELP syndrome?
Elevated liver enzymes.
Yes, Elizabeth.
Auntie, good morning.
Elizabeth, what is HELP syndrome? Once you talk about eclampsia, once you talk about pregnancy-induced hypertension, we talk about HELP syndrome. Yes, Regina, your hand is up. Hello? Regina, let's hear you. Regina, your hand is up. I have acknowledged you. Talk.
Sister, please, it's a mistake.
Twice?
Hello, Prof.
Yes, please.
This is real. It is hemolysis, hemolytic elevated liver enzymes and platelet counts.
Yes.
It is a severe complications in pregnancy resulting from eclampsia or severe preeclampsia.
Or severe preeclampsia. And that is why you can have it in pregnancy-induced hypertension. Thank you very much. God bless you. Okay, Victoria, continue.
We are still under the immediate complication. So during labor, you may encounter eclampsia and then also postpartum hemorrhage. And during per period, there may also be eclampsia, usually within 4 to 8 hours. So within 2 days after the woman has delivered, if critical care is not taken, the woman can experience eclampsia, shock, and then sepsis. Fetal complications. We have intrauterine death, intrauterine growth restriction. We have asphyxia, and then there may also be prematurity.
So these are the fetal complications.
Remote complications. So we have residual hypertension. Sister, please, residual hypertension.
The hypertension, that is, we are talking about pregnancy-induced hypertension, which does not go completely.
Okay.
If it is pregnancy-induced, after pregnancy, it should go, but this one does not. It remains.
Oh, okay. Then recurrent preeclampsia. So it means it may go and come. It may reoccur. And then chronic renal disease. So after delivery, the person will have renal disease. That is chronic. It will not go again. And then there's also risk of placental abruption.
Beauty, what can I do for you?
Sister, please, I have a question.
Go ahead.
Okay. Sister, please, I want to know the correlation between high BP and the eye, in that anytime we talk about preeclampsia, we talk about blurred vision and subsequently dimness of the eye and blindness. I want to know the correlation that lies between the BP being high and it affecting the eye. That's we get the results of blindness and the blurred vision.
What is the correlation between blood supply in the body and the eye? I'm asking you.
There will not be enough blood supply to the eye. So why won't you get the
Irene,
blood?
can you please mute yourself? Yes, Beauty.
Sister, please, I think there wouldn't be enough blood supply to the eye.
It's the same thing. It's the same thing. One thing you must know, if you have not, take time to study hypertension. Hypertension is a killer. Because of the cholesterol in the body, every part of the body is affected. And so when it happens like that, the whole body, the whole systems, the whole organs are affected. But the first area that manifests the complication is the eye, probably because it is very delicate. Abubakar Sadiq, you want to add to what I'm saying?
No, Prof, please, I want to ask a question when you are done.
Okay. So, Beauty, are you okay? The
Yes, sister,
relationship
please.
is that all the organs are affected, but the manifestation comes first in the eye because the eye is quite delicate. Yes, Sadiq?
Okay, thank you, Prof. Please, my question is in relation to the risk factors. We saw new paternity. I don't really understand how change of paternity or a new partner can cause or be a risk factor of preeclampsia.
Sorry?
The risk factors of preeclampsia, risk factors.
Yes.
We had new paternity. So I want to find out how it's a risk factor to preeclampsia. Thank you.
Risk factors. We had what?
New paternity.
Okay, new
or new
paternity.
partner, yes.
New paternity, okay. Assuming this woman has had a new partner. She may have been having her children and no problem, but because there is a new paternity, a new partner who may come with some alteration in the rhesus factor, that could cause it. The issue there is you will ask the woman, have you had children before? Yes. Have you had this problem before? No. Not knowing that it is because of the new partner that she has, the paternity. Paternity has to do with the fetus in utero. And as a midwife, if you have this idea, you will now ask, were your other children from this same man? Hello?
Hello, Prof. Yeah.
Does that make sense?
Yes, please. Thank you.
Yes, Rosina.
Hello, Prof. Good morning.
Good morning.
Please, I want to know the relationship. I heard that maybe children born, maybe I've given birth, I had preeclampsia, and I gave birth to a boy. In the future, when the boy marries, the wife will also get preeclampsia in her pregnancy. Is it true?
I don't know about that. I don't know the theology.
Okay.
That is because the mother-in-law had preeclampsia when the husband was born. So the wife will also have preeclampsia. I do not know the physiology, but we should understand the causes of preeclampsia. And when you have this mother's tales, you will know that. You can understand it if the mother to the girl had preeclampsia. Then you say, okay, it could be familial. Well, I don't know whether it will be like it passes through genes. Probably, I don't know. It's what we have to find out. Hello.
Yes, Prof. I've heard you.
Yes, continue.
Preventive measures. Preventive measures. 1. Regular antenatal checkup. So if the person comes to clinic, we will do regular checkup like protein in urine and then blood pressure of the client so that we can easily detect such condition before it gets to that level. Anti-thrombotic agents, low dose aspirin, 60 milligram daily. So let's say the person has had that condition before. Previously, the person had that condition. So in the new pregnancy, what you can do to prevent it from reoccurring is by administering a low dose aspirin, that is 60 milligram daily. 3. Calcium supplementation, 2 gm per day to reduce risk of preeclampsia. And then antioxidants like vitamin E and C. And also nutritional supplementation with magnesium, zinc, fish oil, high protein, and low salt diet to help prevent preeclampsia from occurring.
So what do you people do in the service area? Do you give all this apart from the regular antenatal checkup?
Yes, Prof, we give. The
Okay.
obstetrician, we refer them to the obstetricians and they give them.
Okay. Go ahead.
Management of preeclampsia. Objectives. So the reason why we manage preeclampsia is to, one, stabilize hypertension and to prevent its progression to severe preeclampsia. Two, to prevent the complications. Three, to prevent eclampsia. Four, delivery of a healthy baby in optimal time. 5, restoration of the health of the mother in puerperium. Treatment modalities, rest and the rest. So the recommended position is that the woman will lie in left lateral position as much as possible. As much as possible. So lying on the left lateral position as much as possible will help. And then also, it lessens the effect of venicaval compression. So it means if the woman rests, it lessens the effect of venicaval compression. Stop, please. Class, venicaval compression.
You will not press the vena cava now. Don't you know that it is all they are saying is prevention of hypotensive what do they call it? Hypotensive syndrome.
Okay, supine hypertension to lessen the effect of supine hypertension syndrome. Okay, so 3, it increases the renal blood flow, that is diuresis. 4, it increases the uterine blood flow, that is, it improves the placental perfusion. 5, it reduces blood pressure.
So when a patient rests, that's the treatment modalities.
Diet should contain adequate amount of daily protein, about 100 g. Total calorie, approximate 1,600 calcium per day.
Calories per day.
Usual salt intake is permitted. So it means you can take salt, but in low doses. Fluids need not be restricted. Sedatives to cut down emotional factor. Mild sedative may be given orally. Phenobarbital 60 mg or diazepam 5 mg at bedtime is given. So the woman may be given sedatives so that the person can rest and bring down emotional or anything the woman is going through psychologically. Diuretics should not be used injudiciously, as they can cause harm to the baby. Placental perfusion and by
diminishing placental perfusion.
and by electrolyte imbalance. Indications for diuretics use are 1. Cardiac failure. 2. Pulmonary edema. 3. Along with selective antihypertensive drug therapy. And then massive edema. So the reason why diuretics are given is what I've just said.
The
Cardiac
reason
failure.
why they are not given, you don't use them injudiciously, except there is real need before you can give.
Okay, sister. Oral antihypertensive drug. Oral metaldopa 250 to 500 milligram TID or QID central and peripheral anti-adrenergic action. 2. Labetalol 250 milligram TID or QID. That is also an adrenoceptor antagonist. Nifedipine 10 to 20 milligram BID. Nifedipine is a calcium channel blockers.
It's
Hydralazine.
a calcium channel blocker.
Hydralazine 10 to 25
Are you all right?
milligram.
Hydralazine is said
Yes,
to be
sister.
a
25
muscular
milligram
smooth muscle
BID
relaxant.
relaxant. Progress charts. We have blood pressure, Q6H. Sir, please, the Q6H.
Quarter hourly.
Culture.
Quarter hourly.
Okay. States of edema and daily weights. Fluid intake and output. So we monitor fluid intake and output. We also examine urine for protein 24 hours. And then blood examination. That is hematocrit, platelet count, uric acid, creatinine, LFT once a week. So once a week, we also do these to check. Methods of termination or induction of labor. 1. Aggravation of the pre-eclamptic features in spite of medical treatment and or appearance of newer symptoms. Hypertension persists in spite of medical treatment with pregnancy reaching 37 weeks or more. Acute fulminating preeclampsia, irrespective of the period of gestation. And then post-term pregnancy.
When you talk of acute fulminating preeclampsia, that is sudden preeclampsia that comes up without signs. So irrespective of the period of gestation, whether the fetus is matured or not, terminate that pregnancy.
Methods of termination, cesarean section. Urgent termination is
indicated and the cervix is unfavorable. Then there is preeclampsia, associated complicating
indicated,
factors,
and the cervix preeclampsia. such as elderly preview gravida, contracted pelvis. So all these conditions will let the physician decide on cesarean section. Hello.
Continue.
Stop, please. I am finished. I read the last one. Associated complicating factors such as elderly preview gravida, contracted pelvis, malpresentation, etc. And I said all these conditions will let the physician decide on cesarean section.
Continue.
Management during labor. So during labor, patients should be on bed. There will be liberal
sedatives.
Liberal sedatives.
Antihypertensive drugs.
Blood pressure and urine output is monitored. Care monitor of fetal well-being. Labor, artificial rupture of membranes, and deliver by forceps or ventus. IV ergometrin is contraindicated. Intramuscular oxytocin is given. Sedation immediately, that is IV morphine 15 milligram to prevent postnatal eclampsia.
Okay.
Management of perperium. So after delivery, there will be close monitoring for at least 48 hours. Tab phenobarbital 60 milligram is repeated for effective sedation. Antihypertensive drugs is given until diastolic pressure is below 100 millimeters of mercury. Patient is hospitalized until BP brought down to safe level and proteinuria disappears.
Definition of eclampsia.
Eclampsia, when complicated with generalized tonic-clonic seizures and or coma, is called eclampsia.
In other words, preeclampsia has graduated.
Pathophysiology of eclampsia. Since eclampsia is a severe form of preeclampsia, the histopathological and biochemical changes are similar, although intensified than those of preeclampsia, as already described. The eclamptic fits are epileptiform and consists of 4 stages that are
epileptic form. They are epileptic form and consist of 4 stages.
That are 1. Premonitory stage. In the premonitory stage, the patient becomes unconscious. There is twitching of muscles of face, tongue, and limbs. Eyeballs are turned to one side, and become fixed. This stage lasts for about 30 seconds.
The tonic phase. The whole body goes into spasms called bronchoepistaxis. Limbs are flexed and hands clenched. Respiration ceases and tongue protrudes between teeth. Cyanosis appears, and this cyanosis, you see it more pronounced in the very light complexion people. Eyeballs become fixed, and this stage lasts for another 30 seconds.